Thank you. I want to first welcome everybody that's here in South Florida that's at this program today. What do we hear from you all? Good morning. Our sponsor, our gold sponsors were EMD, Serono, and Sandoz. Our silver sponsor was Bristol-Myers Squibb. Our bronze supporters, Memorial Healthcare System, Sanofi, and Viatris. Our community sponsors, Mallinckrodt, Alexion Pharmaceuticals, and TG Therapeutics. And our exhibit sponsors, FlowMed Infusions, Genentech, First Choice Neurology, and Novartis. And let's give them a round of applause for being here to do this program today. Thank you. Dr. Jackie Faulkner Rosenthal graduated from Xavier University in New Orleans and received her Doctor of Medicine degree from Morehouse School of Medicine in Atlanta. She completed her residency in neurology at Madigan Army Medical Center in Tacoma, Washington. She has served in both the U.S. Army and the U.S. Army Reserves. After she completed her neurology training at Madigan Army Medical Center, she served as a staff neurologist and a chief of neurology service at Martin Army Community Hospital at Fort Benning, Georgia. Let's welcome Dr. Rosenthal. Thank you.
Hi, everyone. Good afternoon. Everybody get some coffee? We're good. I drank my cup of coffee extremely fast before I came up here, so I'm feeling pretty good. All right, so today I'm going to talk about access to care in underserved communities. It's a topic that I enjoy talking about. And what do we mean when we say underserved communities? So these are our communities that aren't accessing healthcare in the appropriate way. That can include elderly people, people who are underinsured, uninsured patients, people living in rural communities, people with health conditions or disabled, okay? These are all individuals that, again, have difficulty accessing care. When we talk about race and ethnicity in the context of this, it's often because the individuals that are racial and ethnic minorities are going to be overrepresented in these other groups, okay? The problem is being underserved, being at a higher risk for poor health outcomes. So today I'm talking about, again, health equity and reducing barriers. I'll be spending the majority of my talk really focusing on that. And then I'm also going to touch on the ins and outs of telehealth and how to best incorporate that into your healthcare practice. And then how COVID-19 has affected the MS community. All right, so health equity and reducing barriers. Health equity, right? Everybody receiving the healthcare that they should, that they need. It's important to identify those barriers so that we can hit them head on and try to reduce them. So as you talk about barriers to diagnosis and treatment in multiple sclerosis, we know that health inequities are going to be those modifiable differences in access to care, and it's usually associated with economic or social disadvantage. That in and of itself then leads to healthcare disparities, which are going to be those negative differences in outcomes. As I said before, racial minorities tend to be overrepresented in socially and economically disadvantaged groups. So what are these health inequities? Lack of insurance or being underinsured. Obviously, without those healthcare benefits, you could barely get your foot in the door to not only get a timely diagnosis, but also to get the important treatment. And we know with multiple sclerosis, time is brain, right? We want that diagnosis early. We want to get treatment early because that is going to afford the person who has been diagnosed with the best outcome. Lower income. Without having financial resources, it is difficult to, again, access healthcare. Not everybody has paid time off work. Not everybody can take that time. Not everybody has someone to watch their children if they can't take them in for a healthcare appointment. Transportation could be incredibly expensive, especially for MS patients with disabilities that need help. Higher disability, again, that is another really difficult problem for a lot of patients. I'm going to touch on rural communities in a little bit, but it doesn't matter if your MS clinic is across the street. If you can't navigate your stairs, your front door, getting to your car, that sort of thing, it's, again, very difficult to get to healthcare. And again, I kind of touched on it before, but the amount of financial resources required to have somebody medically transported to an appointment, it's very difficult. Lower health literacy. So understanding what it means to have multiple sclerosis, what that means for you as a person, the prognosis, the natural history, the treatments, how to navigate all of that. If there's a poor understanding, that's also going to limit your ability to access care. We see language barriers limited as well, and negative illness perceptions. We heard about this earlier today. There's still a lot of stigma with chronic disease. So again, all of these things lead to lower access care, not utilizing services appropriately, as readily, MRI, for example, healthcare, physical therapy, rehab, that sort of thing. Non-adherence to treatment. So now there's a group of individuals where they may be inappropriately labeled as non-compliant with their treatments, but it's not for lack of effort or want, right? It's for lack of access. We also see lower rates of research participation. And this is really important because we want our research to include individuals of all different backgrounds, racial backgrounds, ethnic backgrounds, socioeconomic status. When we don't have that, then it makes it very difficult to take the findings from our research and apply it to our patient population, who is going to be very diverse. So what about social determinants of health? So this is a term that we often talk about as we talk about healthcare disparities, but social determinants of health are going to be those conditions where we are born into, where we work, where we grow up, where we age, and that can also impact our health separate from genetics and separate from just environment. And so this was a study that was done in 2021 that looked specifically at the impact of social determinants on Black, Hispanic, and Latinx patients with multiple sclerosis. And it does highlight some of the changes and how that does impact health. Economic stability, with there being lower income and higher rates of unemployment. Education, lower health literacy or educational attainment. Really important was how these minority groups were accessing their health care. So lower access to specialty care, and we see that in the Black and Hispanic community not being seen at comprehensive MS centers as readily, and by the time they do get into these centers, there's already a lot more disability present. So there are higher utilization of the emergency department services for care rather than being able to get in with their neurologist. And then a different utilization of services. So lower rates of using case management, lower rates of equipment technology modification services. And these are all really important just for quality of life and being able to engage in the community. And then not using nursing services as well either. Social determinants of health also, again, impact your neighborhood, how you interact in your neighborhood, and then there was a higher poor lived experience of MS in this community. So do demographics matter? Well, we know they do with multiple sclerosis. For example, you look at age, and we've talked a little bit about that. We know the most common age for multiple sclerosis in terms of initial diagnosis, between 20 and 40. But we still see children, unfortunately, diagnosed with multiple sclerosis. And every once in a while, we have somebody maybe in their 60s or 70s that had their first MS attack. So you have to kind of take age a little bit with a grain of salt and not be biased because of that. Same with gender, that matters. MS is an autoimmune condition. And so as with all autoimmune conditions, women are affected more than men, but it doesn't mean men don't get it either, right? Then you look at income and education. Those matter too. When we talk about race, ethnicity in terms of demographics and outcomes, there are differences that we are seeing with regard to outcome. How much of that is biologic and genetic? How much of that is due to social and economic circumstances? So that's really where we need to do some more investigative work. Okay, so this slide right here is just really outlining some of the racial differences that we have seen specifically in the Black MS community. So we see more involvement of the optic nerves and spinal cord in our Black MS patients. We also see that more commonly in our Hispanic patients. As you can imagine, optic nerves, it's your vision. Spinal cord lesions tend to be more highly associated with mobility problems. So these are two areas that can really give a lot more problems with regard to functional status. We see more frequent relapses. Relapses tend to be more severe, and there tends to be a less complete recovery in between those relapses. We see faster transition to secondary progressive MS and higher rates of disability. And beyond that, we actually see that Black MS patients tend to die earlier. So why is that? Why are we seeing these differences? Again, do I think that this is all genetic and biologic? I don't. And it does highlight the need for additional research and additional looking into this. All right, so moving on from here, our rural communities. So this is another area that's very much underserved. You look at it from one standpoint, there may not be but one MS specialist to serve a really large area. And so with that, there can be really long wait times that's going to lead to a delay in diagnosis. But even more commonly, there's no MS specialists in rural areas. And so now you are having to not only wait, but travel. Some people have to travel out of state. In Atlanta, we get lots of people from out of state, unfortunately. And it's not, I'm just going to run to the doctor. Now you have to get hotel rooms, potentially, get travel together. It gets very expensive, very inconvenient. And for some people, it's just not possible. There are efforts to address this, right? On one hand, we really are working on things like this, spreading the word about multiple sclerosis, the importance of being seen early, who to try and see, but also with the healthcare providers, our community neurologists that serve rural areas, to identify early on and try to facilitate early neurology and MS specialist appointments. Also other frontline workers, because a lot of you may not have seen a neurologist first. You might have been an eye doctor, an ER doctor, your primary care. So educating those providers as well about the diagnosis. And beyond that, we need more neurologists in general, right? So helping to, with our trainees, get more trainees in neurology, get more trainees that are multiple sclerosis specialists, and get them to the areas that need that attention. So next is misinformation and lack of awareness. This is another barrier that disproportionately affects our underserved communities. There's still a lot of misinformation just about the diagnosis itself. A lot of people in here have heard before, multiple sclerosis used to be thought of a young white woman's disease, and we know that's not the case. Unfortunately, that bias sometimes has led to a delay or a misdiagnosis in certain individuals. Educating the community about what it means to have MS, as well as our doctors, again, to get that early diagnosis. Beyond that, with treatment, making sure that those living with MS understand how their treatments are supposed to work. If you think that your DMT is going to give you a lot of improvement, that may be disappointing, right? Because we know our DMTs are to prevent the additional inflammatory disease and that sort of thing. And that with any improvements, we really accomplish that through our symptomatic treatments. However, if you're not aware of that, you may say, forget this isn't even working, or I don't want to take this treatment. And then that is going to lead to a poor outcome. We also need to do better with our research. I mentioned this before, but MS research is, I would say, compared to other clinical trials, is even more lacking in racial and ethnic diversity, socioeconomic diversity. And so trying to let people know how to participate in research, what it looks like, for people who just don't want to because they're scared, really reviewing what those safeguards that are in practice now to protect you as a research participant. Discrimination and bias is another barrier, and discrimination and bias in healthcare is unfortunately very prevalent. So again, this is having healthcare decisions made based off of assumptions that are incorrect. And it can happen, I would argue it's happened to everybody in here, and if you don't think it has, you probably just weren't aware of it. But based off of how you look, are you young, are you old, what's your race, are you overweight? Sometimes it's based off of sexual preference, income, healthcare decisions made based on whether you have healthcare insurance. And some, I would say, examples of this that we know about are women who historically tend to be treated more readily than men for mood disorders. Men, Black men in particular, not being as treated as efficiently or effectively for pain. People's complaints just not taken as seriously for reasons that it shouldn't be. It's dangerous for two reasons. First, when that happens, when those assumptions are made and those healthcare decisions are based off of that can lead to delay in diagnosis and misdiagnosis. And then secondly, the person who was potentially discriminated against is now less likely to engage with their healthcare because of that poor experience. These are all kind of, individual examples of discrimination and bias, but an even larger example of this is systemic discrimination. So unfortunately, a lot of our hospital systems that serve our underserved populations are vastly undersourced. And so now it's kind of a losing battle of just not getting the resources that are required. That's a huge problem and definitely beyond the scope of this talk, but it's something that exists and it's something to be aware of. So what about mistrust and safety concerns? So this is something else that is going to impact someone's willingness to engage with healthcare. Sometimes it's like what we just talked about with discrimination or bias. Sometimes there was just a really bad experience that someone experienced, a poor outcome, an unanticipated outcome, and now they're just like over it. I'm not going to deal with the medical system anymore. And sometimes there's a shared experience, and we do see this in the Black community just because of the history of unethical practices that have been faced. And now because of that, even if it wasn't an individual example or an individual experience, there's fear. There's fear about taking on this diagnosis and taking these, quote unquote, scary treatments. This really highlights the importance of having that patient-provider relationship that is where there's a mutual trust, because you as a patient living with MS need to trust that the person that's diagnosing and treating you does have your best interest at the forefront. And then the person that's treating you needs to be able to take in your preferences, your concerns for treatment, and incorporate that in the plan of care. So what about cultural obstacles? The great thing about our country is we have a lot of different cultures, and nobody can be an expert in all of them, but it is important to acknowledge the cultural diversity that we have and how culture impacts healthcare. It can impact someone's reluctance to accept a diagnosis, their willingness to take treatment. Culture impacts someone's belief about what causes illness a lot of the time, and whether they'll follow through with recommendations that are given. It also, culture is kind of highlights the importance of involving the family, faith, spirituality, religion, all of that comes together. And so when it's ignored or not acknowledged by the healthcare provider, it really kind of sets up this baseline mistrust. And so this is another area where we need a lot of improvement. And it's an area where I would say for patients to advocate for themselves and let their needs and preferences be known. Health literacy. So this is how we obtain our health information. It's how we comprehend it and make decisions for ourselves. This too can vary by race, ethnicity, age, income, language preference, and education. Some of the more common examples that we see with MS are going to be with prescription drug directions, which can be very complicated. What's SC? What's an IV, an injection versus an infusion? Sometimes we give you complicated instructions about how to start a medicine, and titration instructions. And that can be overwhelming or easily misunderstood. Health insurance is another one, all this terminology, in-network, out-of-network, maximum, out-of-pocket. For someone that's already fearful with financial constraints, it can be overwhelming and make someone less likely to engage in healthcare or make mistakes on interpretation of their benefits. And then research and consent forms, and really any sort of educational information we have out there needs to be presented in a more easily digestible way. I would say that for a lot of people, if you are reading, a form or a consent form, if you don't understand it, it's probably because they didn't make it easy to understand. The grade level that most of our documents are written at now is too high for half of our population to understand. So this is another place for you as a patient to, hey, explain this to me. This doesn't make sense, and that should be explained to you. So again, self-advocacy. And then shared decision-making. This was brought up a little bit earlier, but it's really important. This is where the patient and the clinician or the doctor are working together to arrive at healthcare decisions. You got to meet somewhere in the middle. You don't want your doctor to just kind of give you an order, take this medicine, this is the best one for you, just do it. You also don't want them to give you 20 pamphlets and say, let me know which one you want to take for your treatments. And treatments with MS really do highlight the importance of shared decision-making because it's so complicated right now when we're making that choice. And they've looked at this. They've looked at decision tools to help aid in that process. And there was a study that when they used this decision tool where the patient could kind of go in and look at the pros and cons of each medicine and help facilitate that decision, and then meeting with the doctor, they found that that whole process was less overwhelming, there was less conflict. And so using shared decision-making can combat some of these inequities, improve health outcomes, and just improve the overall MS experience. So next steps, right? What can all of us do? You in the MS community, family members, us in the healthcare community, what can we do to reduce barriers? We need these kind of educational forums to help combat that misinformation, to increase awareness. And then we need to make sure our populations, especially the underserved populations, are aware of and utilizing the resources that are out there. That may be medication copay assistance programs, coupon programs, support groups. Community engagement is so important. We heard about that earlier as well. And then apps. There's a lot of apps out there for all types of things, for wellness, for exercise. Not everybody can get out of the house or afford a gym membership, but we know exercise and movement is important. Next, seeking a healthcare provider specialist quickly is important. And so we definitely need to make sure we're doing that, that our providers out here are doing that, getting patients seen quickly. But for those of you in the MS community who are seeing maybe you know somebody who was recently diagnosed or has some symptoms that are suspicious and they're just kind of sitting on it and not really going to be seen. Encourage them to go be seen. We need adequate representation in our research and clinical trials, and this is multifactorial, right? We need our research sponsors to be more intentional about where they carry out these studies so that we can get diverse communities involved. We need our investigators to be aware, and we need our community, our patients to be aware as well. Right, as it stands, sometimes it's really hard to participate in research for a patient, so we need to make it easier on you. Enhancing cultural competence and avoiding bias. So that's really accomplished through self-awareness and taking the time to get to know your patient. And even though it may not necessarily seem fair to you as a patient, but take that time to educate the people you see, your doctors. Hey, when you said this, it made me feel this way, or you made this assumption. Sometimes we have to sit in a little bit of awkwardness to make change. And then prioritizing care in our disadvantaged groups. Again, really increasing that resource utilization in the areas that need it most. How can we bring care to our rural communities? Is it transportation programs, vocational support? And then what can you do yourself to help reduce these barriers? And that really is, if you think about our first talk that they had today, truly understanding your own disease state and goals of treatment. You should know what type of MS you have. Is it relapsing? Is it progressive? Is it active or inactive? And with that, you have that knowledge to advocate for yourself with your treatment. You should know what your MRI looks like. And I don't necessarily mean you have to go ask how many lesions you have, but you should have a general idea of what it looks like. Do you have lesions in your spinal cord or not? That's important to know. How your medication works, and how do you know if it's working? You need to know if it's working so that you can be aware whether or not you need to ask your doctor, hey, is there something better I should be on? You need to know how it's working with regard to side effects and safety. Okay, all of our medications work a little different. And when we talk about vaccines and some of these little nuances, it's just education. It arms you with the most information to take care of yourself. Next is developing a relationship with your healthcare team so that you feel comfortable expressing everything, all of your concerns, all of your needs, right? At minimum, your neurologist and your primary care doctor, those need to be really good, solid relationships. You shouldn't have to leave your MS clinic appointment with a bunch of unanswered questions, fear, and concern, right? So if you don't have that relationship, it's up to you to either try to help facilitate that or finding a doctor that meshes with you well, because unfortunately we don't have a cure for MS. And so whether you even require long-term treatment, you're still going to be required to be seen and to be followed. And then lastly, just supporting and educating others in the MS community. All right, so next I'm going to talk a little bit about telehealth and how to best incorporate that into your plan of care. So what is required for telehealth? And as I'm talking about telehealth today, I'm really talking about synchronous telehealth. So that means that the communication is happening in real time, usually with audio and video component. And, you know, telehealth has always been there, but with the pandemic, obviously, it became even more accessible, which is important. And it's something that should stay because there are a lot of advantages to it. So what you need is either a computer, tablet, or smartphone. Again, something that gives you both that audio and visual components, an internet connection, and a HIPAA-compliant platform. That's important. You can't just use FaceTime. There has to be some sort of platform that protects you as a patient. So the good things about telehealth are it improves access and it increases convenience. Two of these things which are already very important for some of our communities that suffer with difficulty accessing care. Current barriers to in-person visits, we've already talked about a lot of this. Financial constraints, a lot of competing responsibilities, geographic limitations, your doctor's just really far, physical limitations, difficulty just getting from place to place, and then infection. Now, this has gotten a lot better, but everybody can remember there was a time where you knew just as many people that had COVID that didn't have COVID. And if you have an infection, even if you're feeling okay, you still don't go to your doctors because you don't want to spread it to other people. And so this allows people to still have their healthcare appointments, even if they're, contagious and don't necessarily want to be around other people. There was a study done at the VA that found that people with MS were more likely than people without MS to have used telemedicine. And this really highlights the importance of using telehealth in the MS community and how they're uniquely positioned to really benefit from its use. So how do we best use telehealth? It's really going to be for patients that are fairly stable, follow-up visits, checking in, routine monitoring, or if there's minor complaints or concerns. I like to use it a lot after I meet a new patient and we kind of discuss 1,000,001 things and we're picking a treatment and I don't want them to necessarily have to make a decision right away. And so we'll do a telehealth visit a week or two later after they've had a chance to kind of think things over, come up with questions. That doesn't necessarily require an in-person visit, but it is something that's really helpful to the patient. Certain types of therapy and rehab services can also be accomplished via telehealth. I would argue that even the majority of counseling and therapy sessions for mental health are carried out virtually. Some types of speech therapy and cognitive rehab can also be accomplished through telehealth. We did for a short time try physical and occupational therapy virtually when we didn't have another option. It's obviously not as good. It's better than nothing. So those are places where it would be preferable to still be seen in person. It's also not great for initial evaluations and diagnoses. It's a lot going on with that first appointment. There's a lot of getting the history, but the examination is vital. And so you can't accomplish that virtually. We can see some things, but if we want to, check tone and sensory and reflexes, those are things that you really want to be seen in person for. I do know at the height of the pandemic, I did meet people who had been diagnosed virtually, and it really is less than ideal. It's also not good when ancillary testing is required. So if there's a lot going on, or maybe you think there's a relapse, it's best to be seen in person because at that point, maybe there's blood work or urine that needs to be checked. Maybe they want to try and get an MRI the same day if your facility is capable of doing that. So those are times where in-person visits are preferred. So as we look at barriers to telehealth access, sometimes there's still lack of appropriate technology. So again, this highlights some of the barriers that our underserved communities may disproportionately face, but having that internet connection or that device to be able to log on. Sometimes lack of private housing or a private space can be a barrier because we do want to try to maintain your privacy as a patient. Language barriers. Now we can access translation services with telehealth. It is a little harder to do. Lack of adaptive equipment. Not everybody has the fine motor dexterity to maneuver a cell phone or a computer or log on or hold the phone up to their face while we're trying to do that visit. And so that's another barrier, and difficulty seeing and hearing. Certain ways to combat this would be to have friends or family kind of come in, help people get set up who may have physical limitations. Sometimes using headphones, if you turn it up real loud, can help people with hearing problems. And then I didn't list this here, but another barrier is just not really knowing about technology and that sort of thing. And there are classes out there to provide education about use of internet and use of different apps and that sort of thing. All right, and so the last topic I'm going to talk about today is how COVID has affected the MS community. COVID in and of itself highlighted a lot of systemic inequities in healthcare, but MS had its own unique challenges. So first of all, who with MS is at highest risk of COVID? Severe COVID, I'll actually say, not regular COVID, but the first column is listing those items that are directly related to MS. So those with progressive MS, those with mobility devices or more disability, and those taking certain immunotherapies, so specifically steroids and our anti-CD20 monoclonal antibodies. And those are going to include things like rituximab, ocrelizumab, that sort of thing. The vast majority of disease-modifying treatments out there do not have any significant impact on your COVID risk. And that is something that definitely took us time to be able to realize, but we can say that now. The second column is listing those items that are not MS related, but are still worthy of mentioning because they still impact our MS patients. So those who are older, Black race, male gender, obesity, smoking, and other health conditions like asthma, COPD, congestive heart failure. So what are the MS specific or MS related COVID complications that we see? It's rare that we see COVID trigger a true MS relapse, meaning there's a new area of inflammation, but it's common to see pseudo relapses, and that's not unique to COVID. Anytime you're sick with something, whether it be flu or COVID or a bladder infection, especially if there's a fever associated, it's likely that you may have a pseudo relapse where pre-existing symptoms are now more pronounced and you feel like the MS has gotten worsened. Some of the more common symptoms that we see with these pseudo relapses are going to be increase in spasticity, increased weakness, increased fatigue. Once the infection is better, those symptoms get better too. We also are seeing higher rates of prolonged COVID symptoms in our MS patients. Fatigue is the most common, and this is still something we're sorting out because it's difficult to differentiate what is long COVID versus that from that multiple sclerosis. And then last is deconditioning. Deconditioning happens in anybody who may be immobilized for a period of time because they're sick or not feeling well. But when you have multiple sclerosis, it kind of hits differently because that reserve now isn't where it used to be. And so it can be more pronounced. And that doesn't go away right away. So even after you've now healed from your infection, whether it's COVID or a different infection, or maybe it was a surgery. It doesn't matter really was, but after you've kind of recovered from that, now it's like you're having to work harder to kind of get back to where you were before because your muscles have weakened. And we saw a lot of increased mental health needs. This too, not unique to the MS community. Everybody in the world was having increased mental health needs during the pandemic. But with multiple sclerosis, you have an immune condition and you're taking immune therapies that impact your immune system. Oh, and there's people dying from COVID. Oh, and we don't know anything about it, right? So there was a lot of fear, phobia, leaving the house, anxiety, and it's taken time. We're definitely in a better situation for knowing how COVID impacts MS, how the treatments impact COVID. But I would argue that we're still dealing with the aftermath and that fear and that lack of community engagement and social isolation that our MS patients have faced. It really has had a long-lasting impact. So we saw some COVID-related disruptions in care. First, changes in disease-modifying treatment. With any disease-modifying treatment, we always look at the risks and the benefits and make sure that the benefits outweigh the risk. Well, when everybody was getting sick with COVID, that risk-benefit maybe changed a little bit. where we thought now the risk of you having a severe infection outweighs the potential benefits of this MS treatment. So for that reason, some people were changed. Their disease-modifying treatments were changed, or maybe they were taken off of that disease-modifying treatment. We also saw delays in infusions. If you have an infection and you get infusions, usually your doctor's going to postpone that infusion until you no longer have that infection. A lot of people were having infections, so a lot of people were having delayed infusions. And sometimes that delay wasn't even coming from us as healthcare providers. It was coming from the patient because they were fearful of coming in and getting that infusion in the middle of a pandemic. And we also saw interruptions in rehabilitative services. A lot of physical therapy, occupational therapy does not happen in its own closed-in room. There are these large communal areas, and for that reason, that was shut down during the pandemic. Home health services weren't as available during the pandemic, and so that had huge impact as well. And this is my last slide. I just briefly want to touch on vaccine information. COVID vaccines are recommended for all MS patients. I really do try to direct people to look at the CDC guidelines, keeping in mind that for most people on immune therapies, that would put you in that special population of having that immune condition where you may access vaccines earlier or more frequently. And we see that with other vaccines, not just COVID, but with shingles and pneumonia, for example. The CDC put out guidance. If you have an immune condition, then you don't necessarily wait till you're 50 years old, or you don't have to get these vaccines. And so you definitely want to check in with the CDC guidelines because they're always changing. But the other thing beyond that is just to know that certain MS treatments can lessen the effectiveness of vaccines. We still recommend you get them because we have not quite figured out the best way to test for the all of the potential vaccine responses. And so we do think that there is still response, but we do know that with certain disease-modifying treatments, that vaccine response is diminished. With that, especially now that we've been living post-COVID for a while, we do have guidance on the best time to vaccinate. And this really applies to those of you who are on those 6-month infusion medications, the B-cell depleters, taking advantage of the time where your B cells are most likely to be coming back up and getting the vaccines then. And the last thing I'll mention about the vaccines is just that it is not uncommon when you get that vaccine, especially if you get a little bit of a low-grade fever with it, to feel like maybe, again, that those MS symptoms are getting a little bit more pronounced. Maybe you're more tired or feeling a little weak. It does not mean that the MS is progressing or it's worsening. It's just that you're having an immune response that actually tells us that vaccine is doing what it's supposed to be doing, and those MS symptoms just are temporarily a bit more pronounced. All right, and that is the end of my slides, so I'll go ahead and take questions.
Great, thank you very much, Doctor. Dr. Rosenthal, first question. Can you give an example or provide examples of discussing cultural differences with a person's HCP?
An example of assessing cultural differences with the HCP?
Can you give an example? Can you give examples of discussing cultural differences? Well, the person asked, can you give an example of discussing cultural differences with my HCP?
So this is a few different ways. So an example, it may be, I hear everything you're saying and these recommendations you have for treatment, but I want my mom and my brother and my sister and my aunt to be a part of this conversation because their opinions are important to me. And maybe we need to come back and revisit this, or maybe they can come to the appointment and you talk with them too. Another example of a cultural difference, there are some cultures that think, that believe that psychological things and mental health things can kind of influence MS, and to bring that up. Hey, this is what someone told me. My aunt told me this. What do you have to? So just bringing it to the forefront and discussing it.
Thank you. You're in Atlanta, and we know that there are lots of issues with people receiving health care in Atlanta. When people are when people are not able to get the quality care at a hospital or a medical center in southern Atlanta compared with Buckhead. What is your response to that?
It happens much more frequently than we would like to. I think that sometimes that you can meet in the middle a little bit, right? Some hospitals have financial assistance programs where we can take individuals that maybe don't have insurance and provide care, but that's not the whole piece of the puzzle, right? You still have to get there. And so another way to try to address that is seeing people at a big center and then working with the community providers to try to work together to provide that care. And that's kind of that. It works well if you have two people that are willing to do that communication, and understandably sometimes that takes time. But it's not a one-size-fits-all answer. You have to look at the individual and what's preventing that care just beyond geography, it being out of a particular area, because it usually is much more complex than that.
Dr. Rosenthal, first of all, thank you for your service to our country. My question concerns the ability to get the comprehensive care that you mentioned, where if a person is not necessarily in a rural environment, sometimes even in other environments. For example, I'm speaking for a friend. So this person called or tried to get appointments with neurologists, sent them their information, and the neurologist says, "Oh, we'll look over your information and let you know whether we'll take you as a patient." That person has seen this on several occasions in several different cities. What can that person do in that kind of situation where the person needs the comprehensive care, where it's kind of a package deal, if you know what I mean?
I would start with the primary care and trying to utilize their resources in terms of getting a referral. Sometimes referrals from another physician are looked at differently than self-referrals. But to answer that comprehensive care question, if you're not in an area or at a facility that offers all of that comprehensive care, which unfortunately most people aren't, that is where you, by coming to programs like this and learning what that looks like, putting together your own healthcare team then, okay? Finding the therapist that works well, finding that urologist, finding that, someone to address mental health. Little things like, getting hand controls on your car. That's not something that's going to be easy by any means. And it may be something that we bring up at Shepherd Center, but that's because we have the clinic or in the same building. And so if someone doesn't have those resources, they may not talk about it. But if you are armed with the knowledge to know that that is something, then asking that of your healthcare providers to try to get that, and doing the research yourself to try to say, okay, these are the things that I know I'm deserving of that would help my overall quality of life, and then going out there and getting it best you can. It's not that easy. I know, like you had mentioned, that your friend they're kind of sitting on the records and not taking them on as a patient, but I would really encourage them to keep trying.
Thank you, Dr. Rosenthal. Thank you for your service also. I want to say that right off the bat. Now, my question is more the opposite of what he just asked. Okay, so, and it doesn't matter where the location is, like whether it's rural or a city. Let's say a person joins a managed care approach, which is a comprehensive approach. So you get a primary, and the primary, if you can't afford a PPO, then you have to go with an HMO. And let's say from previous insurances, you've done all your own research, and the patient has done I'll just say this, in Broward County, there's a zillion neurologists, but there are like not even a handful of MS specialists. And so then on top of that, you have previously already researched and gotten your own urologist and your own therapist. And so you already have your world set up, right? But now you join this managed care program like a Humana or like a Chen Senior Medical or Conviva or, what else? I don't even know what else is out there in the world. And they tell you, no, we have being that you're on an HMO and we give you your referral, you have to go to our doctors. And even though my insurance says that my doctors that I chose, that I did the research on, are in network preferred providers, now this managed care company is saying, oh no, you have to use our in-network managed care providers. Well, that may not be. They may refer you to a neurologist, but not a neurologist that's an MS specialist or a urologist that is like really, really proficient in MS. And so it's like you're in a catch-22 now. And so what does that patient that is in that situation do?
Well, that was a lesson in healthcare literacy terminology. That's a difficult situation. The options are not perfect, but it would be sometimes when you are going to the doctor that they are telling you to go to, you could explain the situation and then try to get a referral to kind of bypass that. It's a lot of work. And sometimes, I know I've had patients before that have kind of encountered this. And again, it really does. It's that healthcare literacy. They signed up for a plan and didn't fully realize how that would impact their current healthcare team until it happened. And sometimes you kind of have to suffer through it for a little bit. And if you could try to find another plan that does allow you to see the providers that you were seeing before. But there's not like a perfect answer to that. Yeah, it's a rough situation and it happens a lot. Mm-hmm.
A person is asking, is there a better state in the United States to find better specialists for multiple sclerosis?
Georgia.
Gosh, I knew you would say that. All right, next.
Yeah, it varies. It varies. Unfortunately, most MS specialists are going to be clustered near academic centers and urban areas. Yeah.
It's very hard to prove discrimination against disabled people because usually it's you and the person that is discriminating you. So there is any way that you can prove that. The other thing is that I didn't listen well. The best time to take the vaccines, if you take infusions, is about 3 months out of your infusion, and these include the flu shot as well, because I'm a healthcare provider and it has like certain dates that you have to fulfill within the institution. And since I am a healthcare provider over here, maybe I can help with the answer for her. No provider you have autonomy as a patient. No provider can impose you the provider that you're going to see, okay? So if you did your research and your HMO said that you can see that it's covered such and such provider, when a provider gives you a referral to see neurology, you can choose your neurology. They don't give you referral to give neurology doctor such and such. So you can grab that referral and go to whoever you think that it's most appropriate to you. Now, if your insurance doesn't cover, your option is to pay out of pocket that provider if they accept out of pocket your referral.
All right, so for the vaccine question, yes, if you're on a B-cell depleter infusion every 6 months, I'm waiting at least 3 months after that infusion and then having it at least 2 to 3 weeks before your next infusion is due, okay? And the closer to that next infusion being due, the more ideal, because it's more likely at that point that the B-cells are starting to replete a bit.
2 to 3 months or 2 to 3 months or 2 to 3 weeks before. So between 3 months and 2 to 3 weeks before would be the...
Yep.
Okay.
Yep. For your question about proving discrimination, it's difficult and it takes a lot of time and resources, and oftentimes it's not possible and this isn't just discrimination against disability, it is discrimination for any reason. But I do think in very obvious of examples, explicit discrimination, that documenting and notifying, I think too many of us are too uncomfortable with the awkwardness. I like to hit things head on. And so if something happened, well, why did you say that? And why are you doing that? I would encourage you to do that with your healthcare providers, because they may be completely unaware that what they're doing is biased or discriminatory. And if you say that and bring it up to them, they hopefully may take that time to kind of self-reflect and change how they interact with others. But in just really, terrible examples, I would say, file the complaints, go through the inconvenient, time-consuming things that it takes, because even though it's going to be a lot of pressure on you, you're helping out the disabled community.
Have you ever seen any adverse effects from COVID vaccine with specific MS patients?
Yes, from any vaccine. So not just specific to COVID, though. All vaccines, if you read potential side effects, there's goofy things that happen out there. I haven't seen anything disproportionately occur with COVID. But yeah, and I do have some patients who the vaccine symptoms in general are just too overwhelming, even though it may only last a day or two, that after weighing their pros and cons, they may say, it's not worth it. Or when I get that vaccine, I feel I can't walk around for a day or two and I don't have anyone to help me. And that's understandable. So everyone's an individual. And I know we make these kind of blanket recommendations, but if there's individual concerns, I would encourage everybody to talk about it with their doctor to kind of come up with the best plan.
Thank you. Next one. Could you tell everybody, please, about the COVID MS registry?
I'm sorry, the what?
COVID MS registry.
The COVID MS registry. I forget the organization that is with, but it's
CMSC.
CMSC. I would encourage, just in general, I would encourage any MS patient to do registry information. That goes for COVID, it goes for pregnancy registries. It just gives us more information, especially on topics where it's really hard to carry out research, clinical trials and controlled studies and that sort of thing. But yes, that COVID registry is just kind of another way to try to get more information about how COVID impacts MS individuals uniquely.
How do you qualify for home health services?
Usually there needs to be some sort of language in your medical chart that documents the difficulty with getting in center, whether it be disability, transportation problems, difficulty leaving your home. And with that you're usually able to get home healthcare services.
You need to make that answer a little longer so I could get up there. Okay, I'm coming up there, and then let's give Dr. Rosenthal a round of applause. Now we have a beautiful certificate for Dr. Rosenthal. Thank you. Thank you for everything. Awesome. Everybody, thank you very much for coming, and thank you all for being online. Bye-bye.